So here is the case of a 50-year-old man who was investigated with MR due to the problems with balance and vision problems and general tiredness. We have discovered that the ventricle system is widened supratentorially with Evans index calculated to 0.36. The sulci are reported normal and the temporal horns are not widened. On the initial scan, we observed that there is something in the aqueduct, lower 1/3. And so conclusion was to make a further investigation with thinner slice T2 sequences to have a closer look at the aqueduct. We could also observe very faint transependymal liquor leaking, not much, but some, and also the upward expansion of the corpus callosum that is indicated clearly the hydrocephalus. So the sequence that we perform is this one. This is an MPR, multiplanar reconstruction of a thin slice packet, three-dimensional, that we can see confirms in good details the thin membrane that is located in the aqueduct lower 1/3. We can also see it here on the zoomed in FLAIR sagittal sequence of good quality. Now this plane is the same as the yellow line that you can see. So we go from the level of mesencephalon cerebral peduncles, we go down, and here we have the aqueduct. We can measure it that normally here at the level of superior colliculus it is about 4 mm wide, and then we go down, down, down till the membrane, which reduces the caliber to about 1 mm, and then it goes back to normal size. The membrane is located 1/3 lower part of the aqueduct at the level of the inferior colliculi. Now anatomically, this is an anatomical embryological development anomaly. And anatomically, this is a junction between mesencephalon, the midbrain, and metencephalon. That is the transition zone, which is the hindbrain. And this is the place where such ependymal webs can be present. So what will surgeons do? When you look here at the sagittal image, you can see a structure sometimes described, it looks like anteater. Anyway, this is the sagittal view of the third ventricle. Here is the third ventricle on the axial plane, slightly widened. And here is the lower part, the bottom of the third ventricle. So surgeons go through the ventricle system with endoscope and they just burn a hole here. So they provide communication from third ventricle into the prepontine cistern. Otherwise, they can also go into the aqueduct and open it somehow, the membrane. So yes, this is the nice case, and in classical obstruction or stenosis, you could also expect the gaping upper part of the aqueduct, which means it opens like a mouth. Here it is not that much. Also, the hydrocephalus is not so pronounced. The patient is 50 years old. It has been very early detected, and but it's a functional aqueduct obstruction, so obstructive hydrocephalus. We also have to look, in case of hydrocephalus on the posterior fossa, location of the cerebellar tonsils, if there is an ectopy, and location of the mesencephalon, if it's sunken or not. In this case, everything is in the normal position. Okay, that's it, the aqueductal web case presentation. If you like such a type of short case presentations, you can view my previous videos. You can consider liking and subscribing, visiting my blog. and I'll see you on the next one.